Giant cell arteritis. Temporal or giant cell arteritis is a chronic granulomatous vasculitis affecting the large arteries of the older people. Most are more than 60 years of age. It is the inflammation of the wall of the large arteries. The cranial arteritis is most commonly temporal, occipital, ophthalmic, subclavian, femoral, or aortic arteritis. Physical examination shows very tender over the temples, swollen rope-like temporal artery, and optic disc swelling due to ischemia. Vision loss is a transient repeated episodes of diminished vision, usually reversible. Sudden loss of vision is only a sign and is almost always permanent. With the loss of vision in one eye, the patient has a large risk of losing vision in other eye. In emergency, give 100 mg of solumedrol and make the patient is taking ASC. Investigation including the complete blood count, normocytic normochromic anemia, and relative thrombocytosis. WBC is usually normal. ESR is significantly elevated and CRP is also significantly elevated. There is a ring of granulomatous inflammation centered around the elastic lamella within the bounding of media. Disruption of the internal elastic lamina, multinucleated giant cells, intimal thickening and fibrosis, as well as central acute thrombosis, non-specific inflammatory infiltrate in the adventitia, and there is fibrinoid necrosis. Prednisolone can be given as initial treatment 50 to 60 mg at a start 50 to 60 mg per day and hold on the dose until the patient is feeling well. The inflammatory markers have normalized. It then begins to slow and wean down the steroids usually after a month or two. Prednisolone 50 mg 1 to 2 months for weaning, then reduce every 5 mg for 2 weeks until 20 mg for a month, then reduce 2.5 mg every 4 weeks until 40 mg a month, then reduce 1 mg every month, total 18 months plus. Most significant complications include visual loss, cerebrovascular accident, stroke. Mortality is due to vascular complications related to inflammation. It may have jaw claudication, scalp tenderness, anemia, fever, weight loss, visual changes, swollen temporal arteries, pulseless temporal arteries, tender temporal arteries, and post biopsy. Risk factors including the age. Women are affected, more common among white and northern European descent. HLA, DRB1, and current smoking or history of smoking, and possible risk factors of varicella zoster. So the common features are headache, scalp tenderness, jaw claudications, ocular symptoms, limb claudications. Infrequent features are ischemia of the central nervous system, tongue claudication, aortic regurgitation, myocardial infarction, peripheral neuropathy, deafness, tissue gangrene. Could have intense acute phase response, anemia, polymyalgia rheumatica, and wasting syndrome. So one need to examine carefully head and neck, erythema, tenderness, nodularity, thickening of the temporal artery, eye examination which include visual and visual fields, optic discs, and retinal examination, assess pulse and blood pressure in all four limbs, listen for the bruise over the thoracic and abdominal aorta, and listen for aortic regurgitation. Differential diagnoses include common migraine, atherosclerosis, Takayasu arteritis, headache, temporal artery involvement due to other forms of arteritis. So patient could be elderly with rheumatoid arthritis, polymyositis, dermatomyositis, or other differentials include fibromyalgia, late onset spondyloarthritis, crystalline arthritis, cancer-associated muscle pain, infection, osteoarthritis, hypothyroidism. So the characteristic lesions include mononuclear cell infiltrates, lymphocyte, isolated periadventitial inflammatory infiltrate. To increase the diagnostic yield, a specimen should have 1 cm long multiple sections examined. So we can do ultrasound, MRI, catheter detected invasive angiography, and FDG PET scan. Symptoms may be atypical, diagnostic uncertainty may exist, and possible large vessel involvement, helped determine the need of biopsy, urgent ophthalmoscopy consultation, cardiology consultation, surgical consultation to obtain the biopsy. So one should consider granulomatous arthritis in patient having unilateral headache, ischemic symptoms of the cervicocranial and upper extremity, muscle stiffness, physical examination, tenderness, swelling, erythema, ESR, CRP elevated, and temporal artery biopsy is a standard. Do not delay in treating the suspected GCA while waiting for biopsy. Start aspirin, methotrexate, and if little improvement, revisit the diagnosis. Aspirin is controversial whether patient have GCA have increased risk of cardiovascular disease. Prescribe low dose aspirin to the patient who have no contraindication to its use. Immunosuppressant medications, methotrexate is associated with potential life-threatening adverse effects. Tocilizumab encourage the result of treating the relapsing GSA. TFA inhibitors not found to be beneficial. So watch for the unexplained increased acute phase reactant. Order the aorta and branch imaging if symptoms of possible new onset of LVV. Monitor the patient of corticosteroid related AEs and ophthalmoscopy. Immunization, varicella immunization may help. Prognosis, the patient with GCA have normal life expectancy, they may have MI, stroke, peripheral vascular disease, visual symptoms, corticosteroid beneficial adverse effect, greatest impact on quality of life.